Hello, everybody. Welcome back. Very excited to have my next guest on the show, Dr. Patricia Robinson. She is one of the experts leading the charge in integrated healthcare as we go into the future. And Dr. Patty, welcome to the show.
Patrick, it's a pleasure to be with you today. Thank
Well,
you so much.
I appreciate you being here, ma'am. We were chatting a little bit before we started. Thank you for the work you do. You were telling me a little bit about what else you've done with the military in your past. Thank you so much. And I gotta ask you, Dr. Patty, what led you on the path to the work you're doing right now? What was the catalyst? Have you always wanted to help people? Because you're doing such great work, you and your partner, Dr. Jeffrey Rader. So,
Well, actually, Patrick, I uh, grew up in Texas, and my family, like so many families, had a lot of challenges.
mhm.
And um, I wasn't on the path to go to college or anything, but, some people, recognized that I had something to give.
Yeah,
I got some scholarship money, and I think um, very early on, I saw a lot of inequity and social injustice,
hmm
and so grateful for having a chance at life, and being um, me and my sisters were the first ones to go to college in my family, and then first for to get a doctorate degree. That was brand new. So I've always wanted to share uh, the kind of grace that I received
yeah.
when I was younger to other
That's
people.
that's and that's why the world needs people like you, Dr. Patty, because you're giving back, especially in an area where a lot of people need it, which is healthcare. Now, can you describe or what is integrated healthcare? For I know what it is, but for the listeners who don't know what integrated healthcare is, what is it, doctor?
Well, I guess I would say non-integrated healthcare is kind of traditional healthcare.
Hmm.
We have separate services for physical health and separate services for mental health or psychological well-being. So if you have a medical problem, you go one place, and if you have a psychological problem, you go another place. And
Hmm.
it's been that way for a long time. And when we look at outcomes, they're not at all satisfying or encouraging. So there's been a movement over the past 30 years, 30, 40 years to look at doing something different. So integrated care represents a range of options that fall in that category of not completely separate and different and trying to be helpful. So I'll talk specifically momentarily about the type of integration that Jeff and I promote and the emergence of this approach. Quite accidental, really.
And it works, right? I mean, because it makes sense to me, doctor, to have everything in one place integrated than to go all these different areas, like you said, correct?
Right. And the reason to do that is because it works. It works better. I'm
Hmm.
not saying it won't continue to evolve and find new ways, but let me just give you kind of long story short. I started out after interning in health psychology in Kansas. I went to Seattle, Washington, and worked there. And I had a split position, part-time research and part-time clinical work in a traditional mental health service. And, you know, um, I was a behavioral scientist and I believed in everything I did. I trained hard, I was effective, and I kept studying and learning. But, it was hard for people to get to me. They waited on waiting list, and then they maybe came just a few times and not long enough to get the whole treatment that I hoped they would get.
Yeah.
So, meanwhile, I was being held to standards like, why aren't you seeing more people? And there wasn't much I could do about it. I worked in a system that was integrated with primary care. Psychological services was just part of the health maintenance organization. And they had a research arm that I worked in. So we started looking at, well, what could we do different to get more mental health services delivered? And so the primary care doctor said, come over here. Everybody's here. Everybody, oh dear, how would we ever see them because we can't keep up with what we're doing? So, of course, that required us to look at working more like a primary care provider and seeing
Hmm.
people more briefly and seeing people at the time of need, more open access rather than these long lines, and being more practical in our approach, just
Hmm.
dealing with the problem the person was concerned about, and engaging with them over the issue of functioning, being the
Yeah.
kind of parent they wanted to be, or being the person they wanted to be in their family or at work. And so, starting to shape something really different. But I participated in randomized controlled trials, which you'll know is like, boy, that's a high standard for
Yeah.
established. And this was in the 90s, and it was with people with symptoms of depression, very, very common problem in our world. And what we did was just offer them a series of 4 to 6 visits, half-hour visits. They were referred by their primary care provider to us, and we compared that with usual care. Usual
Hmm.
care person was sent to the mental health service where they could see a psychiatrist, they could see a psychologist, a counselor, a social worker, and they received cognitive behavioral therapy, state of the art at the time. And what we found was this little 2 to 3 hours of treatment in primary care and these very brief visits in partnership with a primary care provider um, resulted in superior clinical outcomes.
Yeah.
So, less symptoms of depression, better engagement, more people came back, and better satisfaction, higher ratings of satisfaction for the patient, higher ratings of satisfaction for the primary care provider, which before they would just refer and maybe not hear back or not hear much or only after months. And then we did some cost studies. So we looked at the relative value of what we were doing, and this integrated care, this model, emerging model of integrated care, had better value for the very limited healthcare dollar.
Hmm.
But we really didn't know what to do outside of a research study, and you can't do what you did in a research study and scale it up. So in presenting to different conferences, just the research findings, I had opportunities along with other people involved in my research to partner with large organizations like
Hmm.
the Air Force and
Yeah.
later, and then the federal government, HRSA, federally qualified healthcare clinics all over the place, and experiment, figure out what is it we can do. I myself decided I'm going to leave, and I'm going to I'm going to leave the research and
Yeah. Yeah.
figure out what to do by working in primary care. So that's when I went to a rural healthcare clinic, and where there was 4 OBGYN doctors, 4 pediatricians, 4 family practice, and for internal medicine. And we just figured it out over the course of about 7 years, the strategies. And that's when I met Jeff Ryder, my co-author on um, behavioral consultation and primary care. And we decided to write a book about it, what we learned, because people were like, okay, we know it's better. We don't know how to do it. Write a book because you can't.
Yeah, and you did.
We're in our third edition of the book.
Wow. I got to pick that up. Why is it? I got to pick that book up. And for people listening, that's going to be linked up in the show notes. Um, why is it so hard, Dr. Patty, for people to see a mental health provider these days? And I don't know if it's some of it attributed to COVID and how much damage that did to people. I mean, what's the reasoning behind that? I work in inpatient, Dr. Patty, like I told you. So our clients see mental health providers, but they're an inpatient. Now, what happens to the people that aren't inpatient that need to see a mental
Yeah.
health provider? Because it seems like a lot of people are just falling through the cracks.
Yeah, well, there's so many reasons. Let me just start with, just the stereotypes about mental health care
Hmm.
in the world, which is you should not feel bad. You should feel good. If you don't feel good, there's something wrong with you. So there's this whole stigma. I mean, if people are sick, they feel like they should go to the doctor.
Sure.
If mentally unwell, many times people don't want to admit it. They just want to get over it. They want to do it by themselves. So there's that sense of stigma. And that extends to not wanting other people to know that you
Yeah.
have a mental problem. And then we have all these other barriers like geographical access in rural areas of our country. There's just very little access. Like the clinic I worked at, the nearest mental health service was 20 miles away. And most of the people that came to our clinic really didn't have the money,
Yeah.
maybe transportation to get there. If they even, if they could get there, uh, they also face problems with access.
Yeah. Yeah.
Sometimes 2 months to get an intake appointment, maybe 4 months to see a psychiatrist if they needed to see a psychiatrist for some reason. So by then, this whole system doesn't feel good to people. So they might try it, and then, by the time their name comes up, a lot of times they've given up and, whatever, they found some other way to get by. Maybe not a healthy way
I was going to
either.
say, I mean, a lot of times they, like I did, I turned
Mhm.
to alcohol and other things to cope, which is not obviously the healthy way to do it. Um, but yeah, I mean, it's you're just functioning at that point, and you're still need a very, a lot of help, like you said.
I mean, one of the worst things in the world is to ask for somebody to help because you're struggling with your mental well-being and be told that you're going to get on a waiting list and somebody will call you in a
Yeah, that is, I'm fortunate to work for an organization where we don't have that issue because people are on, different tracks and people are, constantly discharging and admitting and stuff like that. So we really don't have that a lot. But is there any, do you think it's gotten better, as far as people seeing mental health care provider, or do you think we're still behind and we need to do a lot better?
Oh, we're still struggling. And I
Yeah.
would say it might be getting worse for a variety of reasons. One is we're losing more people in
Hmm.
the mental workforce because this is very hard on them. They
Oh
don't
yeah.
love.
I told you what I did, Doc, and I haven't been doing it nearly as long as you, but it is mentally draining, but that's why you have to take care of your own being and your own self first.
Yes, absolutely. And then not being able to do what they think is best for people is very hard on them
Yeah.
too. And to do it all alone a lot of times, people in solo practices, and it just takes so long to train somebody. Meanwhile, we have the rates of mental um, unwellness growing, just growing as stresses on the family and on our communities increase. You mentioned the pandemic. Some people are still coming back from that.
Oh
They've
yeah. Absolutely.
stepped back into their social networks. They may not have been able to progress in their career path in the way that they had intended to. So rates of um, stress and burnout among the people seeking help and the people who care for them are still growing
Hmm.
as our workforce diminishes. So we've got to do something really big, and it's hard to turn a big ship around, but that's
Yeah.
what care is doing. It's actually turning two big ships around, primary care and mental health.
Yeah. Do you think, doctor, that what about, telehealth or virtual health or, do you think that's effective? Because I did that for a while with my own mental health, where, had some sessions online. I thought it was, pretty effective, but I can see the pros and cons, I guess.
Oh, well, for sure. But, when you look at the fact that telehealth allows people to get help that would never be able to get help,
Sure.
you don't
Which is
have,
huge, which is huge.
it's huge. It's just huge. It makes it so accessible. And the pandemic was a wonderful thing, and it gave us the reason to lean in and do the research on this and to find out that, hey, this is pretty good stuff. And
Hmm.
people like, and we should give people the option, not,
Yeah.
not force them to get on a wait list and travel whatever 10 miles, 20 miles and pay something, that may cut into their grocery budget.
Yeah.
Uh,
I agree.
we
I
can
mean,
save money.
some option is better than no option.
Well, and it depends on the problem, but looking at telehealth and primary care, it looks like with anxiety, depression symptoms, it's pretty good.
Yeah.
Almost the same as in person. Of course, telehealth doesn't accommodate um, all of the needs of all the people that need uh, primary care, behavioral health providers, including children. So it's very hard to see that 4-year-old or that 6-year-old
Sure.
and what their behavior is,
Yeah.
you know, telehealth visit. So you want to at least do a mix of in-person and telehealth.
Yeah.
Yeah. Uh,
And I like how you mentioned, when you got into this field, it was CBT, cognitive behavioral therapy. But as you know, doctor, now there's DBT, there's EMDR, there's breath work, there's all the different types of holistic, things. That's what we do at my job, FHE Health. I told you what I did, but we take kind of a two-prong approach. We take like the traditional, psychotherapy, the psychoeducation, the talk therapy, and then we do a holistic approach where we're doing, a lot of work with the brain, neurostimulation, EMDR, and stuff like that. And the clients love it. So, integrating everything, putting it all together.
the approach that I train people in terms of a psychotherapeutic approach, the people that work in primary care that I'm trying to help bring to this new role, is a version of acceptance and commitment therapy.
I love ACT. I love ACT.
Hey, you like ACT?
I
Well,
love ACT.
yep. Well, this is uh, at, even before I was doing the research, the randomized control trials, I was looking for continuing education. I went to something at the University of Washington and I met Steve Hayes, the and I went with my partner of 40 years, Kirk Strassel, and they are the co-founders of acceptance and commitment
Yeah.
therapy. So when I was doing the research in primary care, I was already working with these processes of openness, mindfulness, and engaged action, taking action that propel us towards our best selves
Yeah.
day in. So, yeah.
That's one theory that I really gravitate towards, Dr. Patty. I mean, I like DBT and CBT and some other stuff, but I really like, the acceptance commitment. This is how it is. And
Yeah.
what are you going to do? You're going to go backwards or you're going to go forwards? And I can't remember the book, The Happiness. I,
The
I
Happy Trap by Russ Harris.
yes,
I
and I started reading. I got to get back to it. I've just been busy, but I love it.
yeah.
I love it, and that's just how I'm wired. But
Mhm.
what do you think? Um, what about all the problems about burnout in healthcare? We mentioned some of it, like in behavioral and mental health. Well, first of all, Dr. Patty, I'm sorry for the people out there because we keep using mental health and behavioral health interchangeably. What's the difference for the listener, Dr. Patty, between behavioral health and mental health?
So I think the difference is behavioral health is a much more broader
Yeah.
uh, kind of perspective on health. Mental is more like the mental mind aspect,
Psychology behind it, yeah, and stuff.
whereas behavioral health is about all behaviors. Those are actions that we take in the world, all behaviors that influence our health. And we can think of things happening inside our skin as also behaviors because our thoughts, our feelings, our memories, our sensations, they influence our health too. But it's the actions we take in the world. So behavioral health would include uh, like knowing how to take care of our lives, our health, our well-being. So like being able to identify and learn the lifestyle habits that we want to protect our health. So more of a preventive kind of slant on well-being. It would include physical health problems that we might have, like maybe a child with type 1 diabetes
Hmm.
and family, all of those from a behavioral standpoint. It would include, of course, chronic conditions in adults, which are so difficult to deal with. And it's all about behavior and behavior change. But it also includes, of course, our mood states and how they influence our daily choices and behaviors that get us back in the game
Yeah,
and more effective in relating to people and developing the social networks and communities that help us thrive.
yeah. And I think I remember, and I still have a therapist, Dr. Patty. I mean, that's, I'm going to ask you about that. Had her for a long time. Um, I remember my therapist, telling me at one period or one point, life keeps happening, Patrick. I mean, life's going to keep coming at you. But
Mhm.
our goal is to help, build up your resiliency, give you the tools, the foundation. So, if you're facing a bad day, okay, now I know because I learned this in EMDR, to reframe this trauma, whatever, and to not let it affect me as it used to. You know what I mean? Or go back to breath work I've learned, box breathing, whatever. So now I have the tools
Right.
because she told me life's going to keep happening. It's going to keep, you're going to get challenged, but now you have the tools and the foundation to keep going. You might fall a little bit, but now you're more resilient. Would you agree with that?
Absolutely. Absolutely. You know, um, it's just a matter of time, and everybody's going to get something into their life that just totally throws them off
Yeah.
track.
Yeah.
So, trauma is incredibly common in our work in primary care. We see it's almost unusual to see somebody that hasn't had a traumatic experience.
Yeah.
And so, it's a matter of how you respond to what happens. So, from the ACT or focused acceptance and commitment therapy perspective, we would say that
Oh, Dr. Patty.
if we add on a resistance to it, a lot of our energy is going into resisting
Yeah.
and honoring, opening, accepting. so that we can see more clearly the things that matter to us, even while in our darkest moments,
Yeah.
make a choice.
Yeah. And it's so easy to well, it's easier to say, as you know, Dr. Patty, and harder to do when you're talking with a patient to try to get them to realize it. But that's what therapy is, to teach them the tools, and the processes and the best practices to help them get this. Now, I've been seeing a therapist, self-disclosure, for a while now, a handful of years. For the listener out there, Dr. Patty, if somebody, and maybe the listener out there is having, there's a pretty good chance somebody out there is struggling. If somebody starts seeing a therapist or a counselor, Dr. Patty, does that mean they have to see them long term for years and years? I guess it depends on the patient, right? Or the client.
Yeah, well, I think it definitely depends on what the person wants.
Yeah, yeah.
You know, it really should be what you want and what you can afford and what's available to you. Make the best choice for yourself. That's what I would tell the listener. And if it isn't working, don't.
Exactly. But I
Yeah,
think I think my opinion, and I don't know what your opinion is, I'd love to hear. I think everybody needs a therapist at some point in their life, whether it's childhood trauma, ACEs,
yeah,
everybody's dealing with something. And I was and Dr. Patty, I was the typical alpha guy, the first responder military guy where I'm like, I'm okay, nothing's wrong with me until it wasn't.
yeah.
So until I had to reach out and, put my ego aside and get some help. But I think everybody needs help.
Yes, absolutely. Well said. Let me talk a little bit about this primary care behavioral health model in
Yeah, yeah.
answering that, because this is what we did with primary we were like, what can we do that's different from traditional mental health where people go to see a therapist, that is helpful to more people. And so when we answered that question, we said, well, it's got to be accessible, to
Hmm.
more. So to be accessible to more people, it means that the traditional therapist would become a different role. So we call the people working in primary care, we call them consultants, behavioral health consultants. So they consult with a person, their family, they consult with the team, the primary care provider, and everybody together supports that person in making the changes or the experiments that they want to
Wow.
in their, and they do that over the course of the lifespan. So they're not asking someone to come back for a series of appointments. They're seeing them on the same day. They need help. They're working with the problem they have. And a lot of people, about half, just need a nudge. They just need help right
Yeah,
then. See them
yeah,
again till the problem. But the other half need more. So they come back until they start to improve. And it looks like we could see a wide range of people, not just prevention, not just mild, moderate, but people with more severe kind of mental health challenges are responding very well to this
yeah,
approach because it's so accessible,
yeah,
and they have a positive experience. And it's so hard for one person to always be there for you, but for a team of people that know you, care about you, and are supporting you mentally, physically, socially, um, it's you can get in to see somebody.
yeah. That's it, and that's the integrated portion of it, which I love. It's because the old way was antiquated, right, Doctor? I mean, it's just not working anymore. As we go in the future and we change and we learn more about the brain and all kinds of other stuff, like you
Yeah,
said, we need more of an integrated approach, which is what you're doing.
yeah, and there's not a maximum number or a
Yeah,
minimum number. There's not a in terms of length of appointment. Most of the time, they're around a half hour, but sometimes somebody only has 15 minutes. We try to help them. We
yeah,
don't schedule and come back for 30 minutes. We help them with whatever time they have.
yeah. And that's our duty. That's why you're in the business to help, people. I mean, and that's why I love what you're doing because you're giving back. I'm giving back, and this is what I love doing now. I never thought I would be working in this field, Dr. Patty, but I love it. I'm passionate about it.
Yeah. Yeah.
Your book, Consultation in Primary Care, is described as the go-to guide for integrating behavioral health into primary care. For the listeners out there, it's going to be linked up in the show note. Really quick, Dr. Patty, where can listeners find your book?
Well, the easy URL to remember, Patrick, is speaktoyourdoctor.com.
That is simple enough. Speak to your, I love it. That's going to be linked up in the show notes, folks. What are some of the most practical takeaways that you can give the listeners, Dr. Patty?
I would say if you don't have integrated care in your primary care clinic, speak to your doctor. If you go to speaktoyourdoctor.com, there's a tab there. It's a website that's about the book. It's the guide, but it also there's a tab that says speak to your doctor, and there you'll see a information sheet, one page, that helps you kind of find your own words about what kind of service you would like to have for
Yeah.
your behavioral well-being in your primary care clinic. So would you like to have a service that, um, where maybe you have a daughter that just gave birth and needs somebody to support her mood at this point, her sense of well-being. She's struggling. Maybe your neighbor has a son that's using drugs and alcohol, and she's very concerned about it. You would like a service, primary care service, where she would get help for herself, or her son could go and get
Yeah.
help. You can say what you want. But that kind of inspires you. The top half of the worksheet, the bottom half is something you can tear off, give to your doctor, and say, look, these are some things you can do, including the website.
Well, I love you've done the work for the patient right there. And so all
Yeah,
they have to do is just fill out and bring it to their doctor, and then you just
yeah.
give it to their doctor.
Yeah, we've got to change it. We got to change it, Patrick.
Yeah,
We do it. It's the people that can make the difference in the well-being
absolutely.
of their community by changing
Absolutely.
primary care and making mental health care accessible.
The last question, I could talk to you all night, Dr. Patty. What can my listeners do to make their primary care better? You explained some of it right there by helping them with going to the website. What else can they do to make their primary care better? I mean, I ask always whenever I go to see my primary, Dr. Patty, I always ask a ton of questions.
Yeah. Well, I think that they can push for integrated care and hope that that helps the well-being of their primary care provider. So much stress and burnout in the workforce right now. And we know that when we have behavioral health providers on the primary care team, the wellness of the primary care provider improves and the access to medical care also improves.
Yeah.
So yeah, I think that's how you can make it better and go up with your list of things that you're concerned about. And one is how to improve the quality of care for you. How have a expressive, honest relationship with your primary care provider.
Dr. Patricia Robinson. I could talk to you all night, Dr. Patty. I want to thank you for coming on the show. It's been a great discussion. I would love to have you back on, Dr. Patty, because I'm learning from you. And the more I talk to you you and your colleague, I'd love to hear more because it's beneficial to the listeners because you have a
Yeah.
lot of knowledge, expertise. I would love to have you back on. Everything we talked about is going to be linked up in the show notes for our listeners. Dr. Patricia Robinson, do you have any final words before we take off, Dr. Patty?
Just I would like to say that I'm grateful for you, Patrick, and for your show
Thank you.
and the service that you're providing for your listeners.
I appreciate it, Dr. Patty. You're always welcome back, ma'am. It was a pleasure talking to you.
Great. Thank you, Patrick.
All right. Have a good night.